Acute myocardial management. So this is going to be management for like our STEMIs and our non-STEMIs, which we talked about. So you're going to be able to define myocardial infarction, differentiate between non-STEMI and STEMI, and then our nursing interventions for both. So this is our coronary artery circulation, right? So off of our aorta, we have our two branches. We have our right coronary artery, which is going to feed our right ventricle, and then our left main is then going to divide up into our left anterior descending, which will go down the front of the heart, our circumflex, which goes around the back, and then sometimes we can have like an obtuse marginal or a diag also coming off of the heart to provide oxygen to our left ventricle. So angina is chest pain, right? We experience chest pain because we have a decreased oxygen to our myocardial tissue. It can be a chest squeezing, a pressure, heaviness, tightness, right? Patients might complain that they feel like an elephant sitting on their chest, or that they just can't like take a deep breath because there's all of this pressure. This pain can also manifest into their neck, into their jaw, especially in women. They'll complain more of like that jaw or even like epigastric pain. Nausea, vomiting, and indigestion, right? If we are infarcting our heart, we're not able to perfuse the rest of our body very well. So we're not perfusing our GI system very well. And then that diaphoresis and sweating, right? We're going to be vasoconstricting to help provide more oxygen to our heart to provide better blood flow. And so we're not going to be perfusing our skin. That's why our patients get super pale and super sweaty. We break angina up into stable and unstable. Right? Our stable generally follows a pattern after exercise, intense emotions, so like stress from work, any sort of like rigorous physical activity. And so why it's really important that we ask our patients what they were doing when they got this chest pain, and if they stopped doing it, did it get better or did it stay the same? Stable angina is going to be relieved with rest and medication, specifically that nitroglycerin that will give them under their tongue. When they get to the hospital, we can give nitroglycerin through their IV if we need to kind of have some better vasodilation and better control of that pain and improved oxygen to the heart. Generally, their pain is going to be the same type, same area, same sensation, same intensity as they've had before, because we usually have like the same culprit lesion. When we have a difference in this is when we start to get more worried about unstable angina. Unstable angina is like one of the most common types. So again, unstable angina, it's going to not follow this pattern. It is not relieved with rest or medication. Okay, this is our medical emergency. This is our acute coronary syndrome. All right. So treatment, first we're going to say rest, right? Go sit down, put your feet up for 5-10 minutes. If you're still experiencing chest pain, then we can do our nitroglycerin tablets. 1 tablet every 5 minutes. Okay, they can take 2 tablets, then they need to call 911. If it's been 10 minutes total since their first tablet, so they took a tablet, waited 5 minutes, took a tablet, waited 5 minutes, they can take another one. They should really only take 3 at home though, before we intervene anymore with nitro. And it's really important that we ask our patients if they took their nitroglycerin when they get to like the emergency room, just to see what we're dealing with. Oxygen. So not only is oxygen going to help better oxygenate our heart, but it's also a vasodilator, so it can help open up those coronary arteries. We can also give morphine. So morphine is an analgesic, so it's going to help with chest pain. It's also a vasodilator, and it's going to decrease our venous return, so it's going to decrease the preload, which is going to help decrease the workload of the heart. Coronary syndrome, again, it's just kind of a group of diseases where we have decreased blood flow to our myocardium. Something is causing us to have less oxygen in the muscle cells of our heart. Whether it's stable angina, whether it's a non-STEMI, whether it's a STEMI, it could be from vasospasm, it could be from just general hypoxia, all sorts of different things can cause that decreased blood flow. It's responsible for about 1/3 of U.S. deaths in those over 35. So acute coronary syndrome has a very high morbidity rate in the United States. It's a product of atherosclerosis. So we talked about atherosclerosis, how it's plaque buildup within our coronary arteries, making it so that they aren't as big and open and patent, right? There's a smaller lumen, so we're having less blood flow, which is worse when we have that plaque disruption and that vasospasm and a thrombus, right? That's going to result in our occluded arteries. Risk factors for acute coronary syndrome: age. The older you are, the higher your risk. Having a history of dyslipidemia, or like high cholesterol, high triglycerides, even like a low HDL, even if your cholesterol is less than 100, can put you at a higher risk. Hypertension, diabetes, that abdominal obesity, so like that visceral fat, that can just be an indicator of metabolic syndrome, which is also related to diabetes, dyslipidemia. Socioeconomic disparities, right, are patients who aren't able to afford a gym membership or who have to work 20 hours a day and don't have time to go to the gym. They don't have the ability to eat fresh fruits and vegetables. They have to eat processed foods because that's what's affordable or that's what's available. Diet, again, we just kind of touched on that. Limited exercise or that sedentary lifestyle. Alcohol consumption. Alcohol is very myotoxic. It's super toxic to our myocardial cells. And then gender. Being of the male gender just puts you at a higher risk. So what we're going to see on our patients, again, they're going to come in with that chest pain, that radiating chest pain. Their whole chest might feel like it's on fire, elephant sitting on it, and hurts, crampy, all that good stuff. And then start radiating down like their arms, like when they say, oh, my left shoulder and my left arm hurts, or they're numb, their jaw hurts, their back hurts. I told you guys I had that lady, both of her earlobes hurt, and that was her indication of a STEMI, actually. So again, yeah, our females are going to present differently. They present more with like that GI upset, nausea, vomiting, some epigastric pain. Okay, we'll do a whole gallbladder workup on them and it's negative. Then we check a troponin and that's positive. The diaphoresis, sweaty, pale, nausea, lightheadedness. Okay, we're not perfusing our brain very well. Some weakness, we're not perfusing our muscles very well. And then we might see some signs of heart failure if this was an infarct that had happened a couple of days ago, or they've had a non-STEMI for a while. So crackles in our lungs, right, if we're having a left-sided heart failure, or peripheral edema if we're having right-sided heart failure. So diagnostics, so we're going to get an EKG. Okay, anyone with chest pain, EKG within 10 minutes of their arrival. All right, rule out any ST elevation. If we have ST elevation, that's a code STEMI. We're activating the cath lab team, and we're going to get them into the cath lab as soon as we can to get them up an intervention within the 90 minutes of their arrival. We're going to check our cardiac enzymes. Okay, our troponin is cardiac specific, and not only that, but it is myocardial ischemia specific. Okay, this is going to be our best indicator of acute coronary syndrome. A CK, creatine kinase, is just a non-specific indicator of muscle injury. And then our pro-BNP is going to tell us how much of like a left heart stretch we have and how much damage we've done to the heart, how much heart failure we're in. The higher the number, the worse the heart failure. An echocardiogram. So an echocardiogram is going to tell us how well our heart is pumping. So when you guys are reading information on your patients, you might see akinesis of the heart walls. So akinesis means that that part of the heart isn't moving. So if it's not moving, it's not beating very well. So if we have left ventricular wall akinesis, our left heart isn't pumping very well. Okay, so that could be left heart failure or systolic heart failure. And then a chest x-ray, right? A chest x-ray is going to rule out anything else that could be causing chest pain. Okay, there's 10 lethal chest pains. One of them is an aortic dissection, which we can see on a chest x-ray. Also going to let us make sure that we don't have any pulmonary issues such as pulmonary edema, pulmonary like pleural effusion, anything like that, because we are in that left-sided heart failure. Okay, so myocardial infarction, it's another layman's term, is a heart attack. Decreased blood flow to a portion of the myocardium, okay? Ischemia to the muscle tissue. So time is muscle. All right, prolonged ischemia can lead to infarct, which is cell death. And once it's infarcted, we do not get it back. An acute occlusion, even of like 20 to 40 minutes, can lead to an infarct. We have that thrombosis and then a vasospasm, so that's why it's so important that we get these patients treated. We get them their nitro, we get them their baby aspirin, and then we get them to the cath lab as soon as we can. So acute management. So our goal is reperfusion. We want to get them into the cath lab, get them intervened as soon as possible. If you're in a facility that doesn't have a cath lab available, that's when we can give like our thrombolytic medications. Thrombolytics are to be given if you are 120 minutes, so 2 hours away from a cath lab. And then to be transferred within 60 to 90 minutes after we've given that medication. That's our time frame. We also want to then work on pain management and anxiety, so that's another place where our morphine comes into place. Nitrates to help vasodilate. Beta blockers, that's going to just help decrease the workload of our heart, and then our platelet inhibition. So that's going to be our baby aspirin, our Plavix, our Brilinta, our Effient, whatever the doctor's preference is. Long-term treatment, again, we want to reduce that risk of remodeling, which is our ACE inhibitors and our beta blockers. We're also going to want to decrease our risk of dyslipidemia, or help try to control that dyslipidemia. So a lot of times patients will go home on cholesterol medication such as a statin, which is our lipid-lowering treatment. Our antithrombotics, right, so dual antiplatelets, anticoagulants for 30 to 90 days. So they'll be on a baby aspirin and another medication. And then we're going to do tons of education with our patient on lifestyle modifications, medication adherence, follow-up adherence, and the importance of preventing this from happening again. So our non-STEMI, so our non-ST elevated myocardial infarction, these are going to be our, again, an acute coronary syndrome without EKG changes. Okay, flow is limited, but it's still there. We're not 100% occluded. We have a little bit of oxygen getting to the tissue, but not enough to meet myocardial oxygen demand. Right, we might have some stable plaque, vasospasm. It can still be from an embolism, but there's enough blood getting through, or even just narrowed arteries. Okay, we can see this in a lot. You'll hear the word demand ischemia can cause an NSTEMI. So we have a tachycardia generally, or an increased workload of the heart, and we're not able to meet that oxygen demand because we don't have enough blood flowing through. AFib RVR is a big culprit with demand ischemia, because in AFib we lose that big chunk of our cardiac output because we lose that atrial kick, and now we have a tachycardia on top of it. So decreased cardiac output with increased workload, we don't have enough supply and demand. DKA can cause an NSTEMI. Our cardiac muscles rely on a lot of glucose. Okay, and if we're not able to push the glucose into those cells with insulin, then we can have signs of infarct. Cardiac contusion can cause an NSTEMI. Cardiotoxic substances can cause an NSTEMI, such as like some of our street drugs, right? We get in there, they don't have an occlusion, but because of this intense catecholamine response, dopamine response from these drugs, it can cause demand ischemia. Hypotension and hypertension are also ways to cause an infarct without EKG changes and without like that full obstruction. Okay, again, so our assessment, 12-lead EKG, okay, different than tele, 12-lead EKG, our cardiac biomarkers, our physical assessment, right? What's their pain? What are their lungs or their heart sounds? S1, S2, do you hear a murmur? What are their lung sounds? Do we have crackles? What does their skin look like? What's their perfusion? Do they have any edema? All right, we can look at an echocardiogram, how significant that ischemia is. It is affecting the whole heart, part of the heart, right? We're going to look for our wall movement, and then our different types of stress tests. And again, treatment's going to be kind of the same, reperfusion if it's an occlusion, or reverse the cause. Some of our medications for our myocardial infarcts, again, are nitrates or nitroglycerin, aspirin, morphine, oxygen. We do not want to use fibrinolytics in an NSTEMI. Okay, if it's an NSTEMI, we don't need fibrinolytics because they're not 100% occluded. All right, they might be partially occluded, which we can go in and balloon, but they're not 100% included, so the risk versus benefits of fibrinolytics isn't worth it. Medication for management, and then again, treat the cause, right? Reduce our cardio oxygen demand, and then reverse the cause. So if it's DKA, treat the DKA. AFib RVR, reduce that heart rate, maybe try to convert them. Even anemia can cause an NSTEMI, right? If we don't have enough hemoglobin to carry oxygen to our myocardial cells, it can cause an NSTEMI. Okay, so then our ST elevated myocardial infarction, this is going to be a full occlusion of the coronary arteries. So thrombosis so we have a thrombus, then we also have clotting, and then we're also going to have vasospasm. So the combination of those three is causing a full occlusion of one of our coronary arteries. So we're going to see ST elevation in 2 consecutive leads and a J point elevated of at least 2 millimeters. And I don't have an example of one, but I'll get you guys one. So STEMI treatment, right? Immediate IV access. So STEMI treatment is after we've already identified it's a STEMI. We've already assessed our patients. We've already done our 12 lead, like, oh, buckets. There's elevation in 2, 3, and AVF. Let's get this figured out. So we're going to do IV access, preferably like a large bore, like at least a 20. Place them on a cardiac monitor. Okay, monitor their oxygen. Then we need to keep our O2 above 92-93%. And then that PCI within 90 minutes. If not possible, then thrombolytics, we have to transfer them within 2 hours. Again, here's this picture of normal flow, non-STEMI, right? We have a reduction in flow. And then our completely blocked artery. This would be like kind of like a collateral. This one's blocked off, so then we've developed a new one. Our treatment, so PCI is that percutaneous coronary intervention. That's our ballooning and stent. And then again with our same medications. And this is the stenting process. So we go in, go up with a balloon, okay, and then our balloon has the stent on it, and then the stent stays in. And then over time, this will coat with endothelial tissue, and it'll kind of just become part of the vessel. Post-PCI, right, our vitals, and then we are checking our insertion sites and our peripheral pulses and all that good stuff with our vitals. Perfect, right? Any questions, you guys just let me know.